Hazel?
Yeah, let's go ahead and
Okay,
get started.
perfect.
Yeah.
All right, so hi everyone. Welcome back again. Thanks everyone for joining. My name's Amna. I'm an R3 at Stony Brook, and along with Hazel, we're going to be moderating today's session. As you guys know, this is one of many faculty-led board review sessions on RAD Discord, and we're really excited to be hosting Dr. Chick for our first IR board review session. He is an assistant professor at University of Washington, and he's also the associate program director for interventional radiology. We're super happy to have him with us today, especially after having been on call last night. And I'm just gonna turn it over to Hazel to talk through the logistics.
Thank you. Hi, everyone. So my name is Hazel Asumu. I'm a third year at Vanderbilt. I've met a lot of you already and very excited for this IR board review today. As far as logistics go today, so Dr. Chick has a lot of cases that we're going to go through. We're not going to have individual case takers this time. We're going to see a series of cases, and you're just going to write your answers down as we go along. Under the upcoming events, I've posted a PDF and a Word document with like a blank answer sheet if you want to use that to type it in. Otherwise, you can just write it down on a piece of paper or a Word doc on your computer, and then we'll review the cases as we go along. If you have any questions, just post them in the chat box and I'll be moderating that and getting those answered. And remember not to post answers in the chat. Of course, you can like message your friends and that's fine. So with that, I'll turn it over to Dr. Chick and we can get started.
Awesome, guys. Well, thank you so much for having me. I have millions of cases, so we'll get through these. And if you ever want more in the future and you're happy, you can email me, you can text me, you can call me, anything at all. So this is the format I've been doing in general. So there's 59 cases here. It's a bunch of videos. Some go slow, some go fast. But they're limited time, which is grossly to simulate the board examination. Some of these come from word of mouth or things that I saw or others saw. So there'll be about 26 seconds per each scenario. There's multiple questions. So either write them on the answer sheet that you have or just any piece of paper here. And then we'll go over them all afterwards. And then just a plug, thank you for those of you who completed the survey in advance. And there's a very quick one afterwards. And if you complete that, that'd be super helpful for my own sort of research and selfishness. And with that, we'll get going and we'll start and then we'll discuss everything at the end. So just questions at the end. All right, and here we go.
Sorry to interrupt. I'm just gonna, someone just messaged asking about the audio. So for people who joined, I just want to let you know that there is no audio on these. Dr. Chick is just showing cases. So once he's done showing all of them, then he's going to go over them. So if you're having audio problems, you're not, we're just not saying anything right now.
No audio right now. Audio later. All right, so hopefully that was, you saw a lot of cases and hopefully it was quite challenging. Um, I hope it wasn't too easy for you guys. But lots of information here, lots of things we'll go over. Feel free to interrupt me for anything, ask any questions you want. There are no stupid questions at all. You can ask anything at all. All right. So this first one is hypothenar-Hammer syndrome, something that they certainly love on, just trying to find the chat here. So this is hypothenar-Hammer syndrome. It's definitely a case that they love to ask. So you can see this is the radial artery right here coming down to the hand. You can see the hand here. This is the palmar arch here. And when you look over here, the ulnar artery comes and then it kind of just ends right in this area and you don't see it connecting to the palmar arch here. So it's kind of a rare case, kind of a hard case to find. But this is obviously, as you guys know, common in auto mechanics, any kind of machinists or factory workers. And the best way to treat this is to just stop doing the repetitive activity that you're doing. Sometimes they do some kind of surgical bypass around here. It doesn't work very well. There are no real good endovascular therapies, but this is a very classic case of hypothenar-Hammer syndrome.
Hey, Dr. Check, sorry to interrupt. We just had some people request that if you could just pause the loop and just when you're talking about the anatomy so that people can see it.
Yeah, of course.
Thank you.
Of course. Again, so this is the radial artery coming down here. This is the palmar arch right here. This is the ulnar artery, and you can see it's discontinuous right in this area. And the interosseous artery comes down here. Can't necessarily tell which one it is. It might be this guy or it might be this guy. But the key here is just that the ulnar is missing right here. All right. So this is an image from a transjugular liver biopsy. So you can see you have internal jugular access over here, and you have access down with a catheter into a hepatic vein. So this is a right hepatic venogram. So this is what the right hepatic vein looks like. And this is the procedure that you do before, the venogram that you do before you do a transjugular liver biopsy, which is the needle that's right here as you're biopsying the liver. So as you guys know, this can be done for a variety of situations. The main reason we do this over percutaneous is if the patient has some sort of coagulopathy, being an INR greater than 1.5, thrombocytopenia being platelets less than 50,000. If you have any kind of ascites, you don't typically want to do a percutaneous biopsy because you can bleed from the liver into the ascites and you can't control it and you can die. And if you need to measure pressures to determine if the patient has portal hypertension, that's another reason to do this. This case is unusual in that normally this all occurs on the right side of the body, but here we're biopsying on the left, and you can see on the CT that the patient has situs inversus. All right. So this is a right upper extremity venogram, being that we have access to one of the veins in the arm. It could be anything, a brachial vein, a cephalic vein, a basilic vein. And when you, on the venogram here, you can see all these filling defects in the axillary vein here and the subclavian vein here and the brachiocephalic vein here. And you see all these collaterals up in the arm here. So essentially this is a deep venous thrombosis of the upper extremity. This is known as multiple names, either called Effort thrombosis. This is venous thoracic outlet syndrome, or also known as Paget-Schroeder syndrome. They love Paget-Schroeder syndrome for some reason. probably because it's a fancy name that doesn't really mean anything. So this is Paget-Schroeder. It's a venous problem. It's a deep venous thrombosis of the upper extremities. So we typically see this in the dominant hand in a variety of athletes. Typically, we think of tennis players or baseball players as being the people who get this most often. So for the most part, what we do here is we do thrombectomy, remove the thrombus of some kind. We can do thrombolysis, where we drip medicines such as TPA throughout here. We then angioplasty this. But the gold standard that has to be done in all these patients is ultimately they have to have the rib resected, because usually this is either a compression between the clavicle and the first rib, or the first rib and the second rib that ultimately cause the compression here. And if the rib isn't removed, then this continues to thrombose over and over again. So Paget-Schroeder syndrome. This one's a little bit challenging. So this is Berger's disease, or thromboangiitis obliterans. So you guys know, obviously, the corkscrewing appearance. So it's typically found in the lower extremities more than the upper extremities, and it's characterized by these wispy or corkscrew vessels. They're most often very distal in the hands or the feet, but they can be more proximal as well. It's tough to see, but here's the interosseous artery right here, and you can see this corkscrewing here. Here's just a branch off the brachial artery here, and then down in the hand, you can see this branch here. It's incredibly hard to find a good case of this, but again, for some reason, they like these kind of things. You get these distal necroses in the fingertips for this, and the real treatment is smoking cessation. This could be some kind of vasculitis, NOS, in general, but the corkscrewing is sort of the helpful component. All right, so this is an image from a nephrostogram, or an image of the kidney. So this is a double J or stent, which can either be placed by our IR percutaneous, or it can be placed from a retrograde fashion through the bladder and upwards by urology. So the best place to place the nephrostomy is this inferior calyx here, typically the inferior most and the posterior most calyx. This area of Brodel, as we call it, because in theory, this is the region that's most avascular. There's less vessels in this area, so you'll have less bleeding. And also importantly is you won't cross the pleura if you come low here. So if you come high, you can cross the pleura and develop a fistula between the kidney and the pleural space, essentially leak urine from the kidney into the pleural space. There certainly are times where we do access these other calyces up here, particularly if you're trying to remove a stone that's in the upper pole or in the mid pole. Some of these other accesses may be more appropriate, but in general, you should come to the inferior most and the posterior most to access, and that's E. All right. So this is a kidney right here. So this is a renal arteriogram, which means that we're interrogating the renal artery. So this is the right renal artery. And the injection rate to obtain this is 5 mLs per second for a total of 10 mLs. So that's probably meaningless. It certainly was at my point. But unfortunately, they actually do test this on the test. It was on my test, this one in particular. And there's no great way to know this. So the rate, the 5 mLs per second, the number associated with the rate, or the very first number, is roughly the size of the vessel. So if you're given a bunch of choices and it's a very tiny vessel, the first number should be very small. While if it's a giant vessel, the first number should be very large. So this is about a 5 millimeter vessel in diameter. So we use 5 for a total of 10 mLs, meaning that we are injecting 5 mLs per second for a total of 10 mLs. So it's a 2-second injection. Frankly, I don't think it's really important to memorize or to know them all, but the renal one was on my test. It's kind of silly, but it is what it is. Just remember the first number corresponds roughly to the diameter in millimeters of the vessel that you're in. So this is a renal arteriogram, but you can see that the half of the kidney down here is missing. So this was a trauma patient. who had a lower pole transection, and you can see just the lower half of the kidney here is devascularized. And definitely just shout out if you have any questions. So I'm going to let this one play for a second. So this is an image where we're in the celiac artery. So initially the splenic artery is filling here, and then really fast you see the splenic vein filling here. So you should never really on the same image see both of these things filling. So this is the splenic artery coming out to the spleen here, and then you right away see the splenic vein filling. So that should never really happen unless there's some kind of abnormal fistula here. So this is a trauma patient that had some connection. So this is an arteriovenous fistula. Again, something that they seem to like. If you see the vein filling way too fast, you should think of arteriovenous fistula. This can also be seen in something really weird called hemangiomatosis. It could be that in this case because there are all these hypervascular or rounded masses throughout the spleen. But this was also a trauma patient, so it's probably just a traumatic AV fistula. What is a good way to tell vein? So there's no like great way other than following the course of it. So it would be hard to know, especially for someone who doesn't do this very often, to know which one is the artery in the vein. Frankly, the first one is going away from the catheter towards the organ. So the one going away towards it is the artery because it's feeding the spleen here. And then the one coming back centrally is the vein. But it's kind of hard to know. And it's just the real key here is that they fill almost at the same time, and they really shouldn't. All right, so this is an AP image or anterior posterior image of the head. So A is the superior sagittal sinus, B is the sigmoid sinus, C is the torcula, and D is the transverse sinus. Okay, so this is a transjugular intrahepatic portosystemic shunt, or a TIPS procedure. So we have right internal jugular vein access here, and then we have a sheath down into the portal vein. So this is what the portal vein looks like normally. This big vein here, and then this is the right and the left branches of the portal vein. This right here is called intracardiac echo, and this is the basically echocardiography guidance, which helps us do the TIPS procedure, is that little thing here. So during the TIPS procedure, you connect the portal vein through one of the hepatic veins to the junction of the right atrium and the IVC. And this thing is called a Viator. It's a very special stent that you use for TIPS because the end of the stent here is uncovered. It has no fabric on it because you don't want to block any of the portal vein branches, so you leave it uncovered, while the track that goes through the liver itself is fully covered with graft material, so that you basically it serves as a conduit and you don't essentially bleed directly into the liver. So it's called a Viator, and it's really the only place that we use this kind of special stent. So that's the TIPS. And I should say the three real indications for it. So the first one is uncontrolled variceal hemorrhage, specifically esophageal varices, refractory ascites, or ascites that happens over and over again requiring paracentesis, hepatic hydrothorax, or the collection of fluid in the lung, and hepatorenal syndrome are the primary reasons to do this procedure.
Dr. Chick, could you go over the absolute contraindications for TIPS? I feel like there's some like controversy in like some of the material I've read as far as if there are absolute contraindications, or like what would be tested on.
Yeah, so I can't think of many like extreme contraindications. So a little bit of it depends, like how aggressive you want to be with something and the situation that someone is in. So we tend not to think, I think, anymore, although I know you guys are tested sometimes, on relative and absolute contraindications. I just sort of think of the things that would give you pause more likely and that you should really think about. And I highly doubt they're going to have you like split hairs. So one thing is hepatic encephalopathy. So obviously this shunts blood around the liver from the portal vein to the right atrium, and you no longer detoxify patients. So if you have profound confusion to begin with, you wouldn't want to do this procedure. If you have a coagulopathy, being an INR greater than 1.5 or platelets less than 50,000, it would also be kind of unwise to do this procedure because it's aggressive and it's the risk of bleeding is quite high. Intrahepatic lesions, specifically HCC, is another contraindication because they tend to bleed a lot. So you don't want to pass the needle and pass the entire device through the solid mass itself because you'll bleed and you can basically die from hemorrhage. And the last thing I tend to think of as a contraindication is profound right heart pressure because essentially you're shunting blood from the portal vein through the tips to the right heart. So if you've already got elevated right heart pressures, you could, in theory, push someone over into heart failure. So those are the main things that I think of.
Thanks.
Yeah, of course. So someone asked, how would you measure encephalopathy to know if a TIPS is contraindicated? So usually we don't actually measure anything. The ammonia levels and everything are not really helpful. It's grossly just a clinical judgment on what the patient sort of seems like. And then are they taking lactulose or rifaximin? Are they maxed out on those medications? And more just like a gestalt if they're like confused to begin with. What is the pressure cutoff for right heart pressure? So typically we think of usually between 5 and 8 as being a normal right heart pressure. Is like a normal thing. There's no absolute number to say you can't do this, but if the patient has a right heart pressure of like 25 millimeters of mercury, you probably should kind of like think about, do you really want to do this? It doesn't mean you can't do it. I've never seen a patient go into heart failure from this, but it's more like a theoretic thing that could happen. All right. So there's a catheter here from the upper extremity, either from a brachial artery or a radial artery access. This is an image of the aorta going down here. And then you should see the iliac arteries down here, but you don't see them. And you just see all these kind of tortuous collaterals everywhere. So this is aortoiliac occlusive disease, or essentially atherosclerosis of the aorta and iliac vasculature, also known as Leriche syndrome. So these patients get decreased pulses in their lower extremities. They have claudication and erectile dysfunction. So you can recanalize or burrow through these things and place stent grafts across them to reconstruct the aorta and the iliac veins, or you can do some sort of bypass, like an aortoiliac bypass or an axillary artery to femoral artery bypass. You could do a variety of things. But the key here is just that the aorta down here is cut off and you don't see the iliac veins or iliac arteries. All right. So this is a patient with HCC. So you can see this hypervascular mass here, and then you can see washout and the pseudocapsule afterwards. So this is hepatocellular carcinoma. So the Milan criteria for these, the Milan criteria are used to decide who can get a liver transplant and who can't. So you can have one single tumor that is less than 5 centimeters. You can have up to 3, which are not larger than 3 centimeters. You can't have any vascular invasion, and you can't have any spread outside the liver. And as long as you're within Milan criteria, you're eligible for liver transplant. So a single solitary lesion like this, there are a variety of curative treatments. So one would either be ablation, One would be hepatectomy. And then now we sort of think of radioembolization as being nearly curative. Other things such as chemoembolization and bland embolization and SBRT or radiation therapy are usually not curative. So if you had to cure this patient, the best options are either to do some kind of hepatectomy to remove it entirely, or the real best thing is ablation, where you just burn or freeze it to death, basically.
Dr. Chick, would we have to choose between like radio frequency versus the Y90?
No, I don't think so. I mean, so I break them up into like sort of a couple things. So you should really know that ablation could either be microwave ablation, it could be radio frequency ablation, it could be cryoablation. You don't need to know the nuances of them all, but the important part of that is those procedures are essentially treated as curative, where treatments, transarterial treatments such as radioembolization, where you put radiation particles, or chemoembolization, where you put chemotherapy, those are really palliative. They're not curative. Radioembolization is becoming more curative these days by using really high doses of radiation through the arteries. But I don't think you really need to know the absolute specifics of each. All right. So this is an injection from the left internal jugular vein. You can see a catheter in the left internal jugular vein. You have this little nub in here where you should have the right-sided superior vena cava, but it's over here on the left. So this is a left-sided SVC or left-sided superior vena cava, and that drains through the coronary sinus. I don't know why they like that, but they like that it drains through the coronary sinus. Okay, so this is an injection through the catheter, and around the catheter you can see this sort of like collection, or what we call a fibrin sheath. So basically that's just adherent debris on the catheter so when you flush the catheter, the debris gets pushed away and the catheter flushes fine. But when you try to aspirate the catheter, this debris sticks to the catheter and gets stuck, and the catheter will not aspirate. So a catheter that will flush but will not aspirate is diagnostic of a fibrin sheath. So in order to treat that, you can do a variety of things. You can do fibrin sheath stripping, which is done here. You have a snare up from the bottom and you're pulling that fibrin sheath off of the catheter here. Another option is to remove the catheter, angioplasty this area to disrupt the fibrin sheath, or you could replace the catheter altogether without angioplasty, but you might put it back into this pocket of fibrin sheath, and that might not work so well. So this seems like a stupid thing, but I had about, on my boards, I had about 6 questions of this exact same thing, this same kind of video over and over and over again, and a snare from the groin over and over again, pulling on a catheter for fibrin sheath stripping. So it's kind of an obscure thing, but whoever was making questions that year seemed to really like that. Let's see what else we have. Is there a size cutoff for treating HCC with RFA? So not grossly. Most of us think less than 3 centimeters, roughly. But with some of the new technologies, such as microwave ablation, which is slightly hotter and slightly more aggressive, some people can treat up to 5 centimeters. But roughly we think of 3 centimeters as the size cutoff for it being truly curative. Does the fibrin material get removed from the body, or do you need a thrombectomy device? So technically this is just a little bit of like a little tiny cap that just makes like a DVT and just goes to the lungs. So it breaks off, it goes through the heart, and it goes through the lungs, essentially with no consequence. So it's like a tiny little PE, like microscopic PE that we all can sort of tolerate, and no one even knows they got it. So that's fibrin sheath stripping. All right. So it's kind of challenging. So this is a catheter that goes through the skin, through the liver. It's called a reverse curve catheter because it looks reversed like this. And then the injection, this is what the portal vein looks like. So this is called portal vein embolization, or basically you shut down the portal vein. This is the angiographic appearance of what glue looks like, or cyanoacrylate is another name. So it's essentially glue. It has this kind of like cast-like appearance. So essentially what you do here, this is portal vein embolization. If you have a giant tumor in the right lobe and your left lobe of the liver looks really good, what you do is you glue all of the right-sided portal veins shut, and that causes the left side of the liver to get really, really, really large, and then they can resect the whole right side, and you have basically a giant left side, which is enough to survive. So in a non-cirrhotic, the amount of liver that you need on the other side to survive is 20%. In a cirrhotic patient, because your liver doesn't work that well, the amount of liver on the left side that you'd need to survive would be higher. It would be 35%. This is another one that they love. So this is a renal arteriogram. So catheters in the left renal artery. This looks like the entire kidney. And you can see this ball up here with all these chaotic vessels here and these little lakes. These lakes are nearly pathognomonic. So are the tiny vessels. So this is a renal angiomyolipoma. They always look like this. Always these little tortuous vessels with the dark lakes here. Again, they always ask, it's always in tuberous sclerosis. So these can be treated with a variety of what embolization is essentially what you do for these. So you go through the artery and you put embolic material in them. You can do a variety of things. There's no absolute right answer. Most people use alcohol and ethidized oil. So ethidized oil is called Lipiodol. So alcohol is, you can't see alcohol. So you put ethidized oil in here, which is just an iodine component, so that you can see as you're putting alcohol in it, and the alcohol denatures the arteries and kills this thing really fast. Another option is to use particles, small particles, because essentially this is like a tumor. And so for most tumors, you should use very small particles, which we typically say are 100 to 300 microns, because they are very small, they penetrate very deeply, and they kill the tumor. So if you see a tumor embolization, always use small particles. So we say 1 to 300 microns. You don't want to use coils here because this is essentially like a vascular mass that just will recruit different vessels. And if you use coils, you'll sort of block your pathway into these vessels, and you won't be able to stop it. So the real answer is either alcohol to kill this or particles. So it's very hard to differentiate between an RCC and an AML on angio. Very, very hard. So AMLs typically have these lakes, these dark lakes here, and the very tortuous vessels. RCC typically has arteriovenous fistula. So again, you'll see the artery filling, and then you'll see the vein filling relatively quick. But it's hard to see RCCs unless they're huge on angio. So I highly doubt you would have to differentiate between the two. And I don't know, probably the aneurysms. I don't know what that necessarily means. These guys? I don't, these I think are just little dead spots of the tumor that have outgrown the vascular supply, I think. But AML, and know that it's associated with tuberous sclerosis. Okay, so this is a little bit tricky here because I turned the image here. So this is an AP image from the lower extremity, a lower extremity arteriogram or a lower extremity runoff. You can see the hardware here in the femur, and you can grossly appreciate that this is the knee here. So they love the lower extremity anatomy and labeling things. So this is the superficial femoral artery right here. B is the below the knee popliteal artery. This would be the above the knee popliteal artery right here. C is the tibio-perineal trunk. D, the first branch that comes off is the anterior tibial artery. And E is the posterior tibial artery. And this is the perineal right here. So definitely look at a picture of the lower extremity vasculature because they like that. Okay, so this is an image from a pulmonary arteriogram. So you got a catheter that's in the right pulmonary artery here. And you can see there's this giant filling defect here in the right main pulmonary artery. So this is a pulmonary artery arteriography with a PE. So you can treat these in a variety of ways. You can do thrombectomy. You could give anticoagulation. You could do thrombectomy to take it out, or you could do thrombolysis where you basically drip TPA or drip medicine to break it up. So PE is broken up into 3 different kinds. You have non-massive, you have submassive, and you have massive. So non-massive PE is any kind of PE without any evidence of right heart strain. So typically we treat those with just anticoagulation alone. So submassive PE is PE with evidence of heart strain, either on echo or CT, but no hypotension. And this is a little bit of a gray area. Sometimes we treat these with anticoagulation. Sometimes we treat these with thrombolysis or thrombectomy. And then finally, massive PE is PE with heart strain and with hypotension. These are the ones that typically we treat with either thrombectomy or thrombolysis or intravenous TPA because these patients are usually sick. It's a little bit of a gray area. They're not always treated exactly this way, but that's roughly the criteria. All right, so this is an image from a lymphangiogram from thoracic duct embolization. So we have the catheter in the thoracic duct here, and you can see this very tiny thing in the middle of the chest in the mediastinum here, going in the posterior mediastinum all the way up here, and then dumping into the jugulovenous angle. So we do this if patients have a chylothorax or chylous effusions, essentially. And this is most commonly from esophagectomy. Esophagectomy is the #1 cause of thoracic duct injury. Other thoracic surgeries, such as heart surgeries, are the second most common cause. So typically we think of criteria to do some sort of embolization of a thoracic duct being high outputs, being fluids more than 1 liter per day, and with triglycerides greater than 120 milligrams per deciliter. And this number, again, as stupid as it is, was actually on my test. So abnormal triglycerides or hypertriglyceridemia is greater than 100 milligrams per deciliter. Okay, so this is an adrenal vein sampling, adrenal venous sampling. So these are sampling of the adrenal glands themselves. So these are procedures that we do in patients that have primary hyperaldosteronism, or essentially hypertension that is not of kidney origin. So this is hypertension that arises from some extrarenal source, and the most common cause is the adrenal glands. So what we have here is, this is a catheter that goes in the IVC, and then it's in the right adrenal gland. You can also almost appreciate it here. They say it looks like a clover or a leaf right here, and then they're always marked by these retroperitoneal venous collaterals here. This is a left-sided adrenal vein, which comes off the left renal vein, which is right here, into the left adrenal vein here. And again, maybe you can hallucinate that there's a clover type thing here, and then these retroperitoneal collaterals. So when we do these procedures, we sample cortisol and aldosterone from these veins themselves. Then we do some calculations, and it tells us whether the left adrenal gland is problematic or the right adrenal gland is problematic. And then they're surgically resected to treat hypertension. Okay, so this is a splenic artery aneurysm. So this is the catheter here is in the celiac artery, and then the splenic artery, this tortuous thing is filling here, and then you can see the spleen over here. So this very rounded structure here is splenic artery aneurysms. These are true aneurysms most often, meaning all three layers are involved, and that it's not traumatic or anything. Most of the time, these are just truly incidental, and they kind of develop with time. Most often, they present with no symptoms at all. They're just found routinely on CT or any other sort of imaging that the patients have. So these can be treated a variety of ways. If possible, they can be excluded with coils. They can be a little bit challenging because in the ideal situation, you don't want to just obliterate the entire splenic artery. So if it's off of a branch, it's sometimes possible to just treat the aneurysm itself. If not possible, you consider putting a stent graft across it, which is a covered stent, so that the aneurysm itself is excluded, but the splenic artery itself is sort of preserved. It's beyond definitely what you need to know, but there are a variety of different ways to treat them. How can you tell pseudoaneurysm on this image and tell if it's related to pancreatitis? So you probably couldn't, frankly. A pseudoaneurysm and a true aneurysm really look the same. It'd probably be based on history alone. I mean, I highly doubt I couldn't differentiate from this picture alone right here whether or not this came from it totally being asymptomatic or came from pancreatitis. You can't really tell. I will say true aneurysms tend to be really round and really sort of symmetric on all sides, where pseudoaneurysms can be, kind of like a blown out artery, and it can be different in various dimensions. But it's very hard to tell. You couldn't really tell. So the size criteria, again, is something that comes up, and it's hard because I know sometimes they say 2 centimeters, but even that is not absolutely hard and fast. So typically we don't do anything in these unless they're greater than 2 centimeters, unless you have special situations like pregnant patients is the one I think of, and I think the one they test on. That really corresponds to only splenic artery aneurysms. We kind of roughly use the same guidelines for other aneurysms, but it doesn't, definitely not a hard and fast. So like when I get asked often, what about a renal artery aneurysm? And I don't think there is an answer. I roughly use the 2 centimeters again. If it's larger than 2 centimeters, I tend to treat it, but I don't think there are any guidelines that say you absolutely. I think 2 centimeters is probably a smart number to know, but it's a little bit variable. Can you point out the neck of, so you can't see the neck of the aneurysm in this case. Actually, I think the artery goes through the entire aneurysm. So this one would be one that you couldn't really get rid of. So we put a stent across this one ultimately. So it comes in here, and then it basically goes through the aneurysm and back out here. So this is not really a side branch. This is like straight up in the middle of the artery itself. So there's no real true neck to this one, I don't think. In a pregnant patient, do you treat the aneurysm despite the size? Again, there's no absolute answer. It depends on the size, I think, again. So I've treated them certainly if they're large or approaching 2 centimeters, but also if they're relatively small, you kind of have to just gauge the risk of, do you want to put the patient through some sort of actual procedure with radiation risks when you probably can just wait. So I'm not trying to be vague, but there's I'd say on the test, if it said, when would you treat this? Less than 2 centimeters, I would say pregnant patient. In real life, you kind of got to think about all the risks and benefits and everything. All right, so this is what carbon dioxide looks like. on IR imaging. So it's not black like contrast. This is basically like air. So it's always white. So if you see any images that look white like this is CO2 or carbon dioxide. So this is what we call a BRTO, or a balloon occluded retrograde transvenous obliteration. So TIPS is the treatment of choice for esophageal varices, while BRTO is the treatment of choice for gastric varices. So essentially what we do here is, one second. So I don't know why it doesn't like that. Might just let it play for a minute. So we have a catheter here that's transvenous. So this catheter here is in the left renal vein right here. And this is a balloon that's blown up in a splenorenal shunt. So a connection between the splenic vein and the renal vein. So what we do for gastric varices is we go backwards up into the renal vein, up into the splenorenal shunt, and we inject. And you can see these are all the gastric varices right here. And then you can see that they communicate backwards with the portal vein, which is right here and right here. So this is the portal vein over here. Definitely beyond what you would need to know. But the important thing is that BRTO, or balloon occluded retrograde transvenous obliteration, is the treatment for gastric varices, not TIPS, not anything else. This is the best way. And so what we do is we basically sclerose or obliterate these varices. So going through this backwards catheter, we put either some kind of detergent, something that we call STS. It's basically just like dishwasher detergent that basically denatures all these and destroys them. And then we put little plugs down here as well, so that the detergent doesn't spill into the normal renal vein and into the kidney itself and destroy the kidney. So BRTO is the treatment of choice for gastric varices. This is what contrast looks like, CO2 looks like on IR imaging. So the connection, so the connector is not by the left gastric vein. The connection is via the left renal vein here, which then goes through the splenorenal shunt here, which then goes through the gastric varices, which then usually goes through the splenic vein itself, which is right here, and then to the portal system. So this is FMD. So you can see this is an aortogram. You can see the irregularities here of the renal arteries on both sides. So it's not even, it's very irregular, looks different on both sides. So this is FMD, most commonly seen in the renal arteries like this. So it's some sort of non-atherosclerotic, not PAD-like process. And the important thing, well, it's what they like to test, but the treatment of this is angioplasty only. Do not place a stent. That doesn't mean that you couldn't place a stent, because it certainly can be done. But most of the time, this responds to angioplasty alone, and you don't need to put a stent in these patients. And they absolutely love that, showing images. And the answer is angioplasty, do not stent. Exactly. So what is the rationale behind not stenting? Again, you could stent. It's just kind of like dogma. The thing is, if you don't have to leave a foreign body in a patient, it's better not to, because once you put a foreign body in them, they tend to be also problematic. Stents tend to occlude. Stents tend to develop stenoses. So technically, this responds so well to angioplasty alone that you don't need to leave a stent. Other specialties sometimes do leave stents. It's not like a disaster. But for some reason, radiologists and interventional radiologists and everyone seem to really love the do not stent this and only angioplasty. So the real answer is just angioplasty. All right, if anyone got this, I'd be very impressed. So this is SAM, or segmental arterial medial lysis. So SAM is kind of a wastebasket thing, or a very rare thing that we see. that basically presents with unexplained hemorrhage somewhere in the body, and then all the arteries have aneurysms and dissections and occlusions and all kinds of weird arterial findings that you can't explain. And it always usually starts just with like hemorrhage somewhere for no reason. So intra-abdominal hemorrhage with all kinds of arterial abnormalities is the hallmark of SAM. So you can see this is a replaced hepatic artery off of the SMA. So this is the SMA and this is the hepatic artery, and you can see all these giant aneurysms off of here. You can see some stenoses here. You can see some occlusions here. And then off of the rest of the SMA, you can see like a bunch of little fusiform or tiny little aneurysms everywhere. So this is SAM. Segmental arterial medialysis. There really is no amazing treatment. Steroids don't work. Nothing works for this in general. But what we think most of the time is you can coil off a few of these guys to treat the acute bleeding, and then you kind of just watch them. But there's no, like, we don't understand, is it like atherosclerotic? Is it infectious? Is it what? We just don't really know. So that's SAM. All right, so this is a catheter that's in the superior mesenteric artery. Then you have a microcatheter down into one of the mesenteric vessels, specifically the IPDA here, or the inferior pancreatic duodenal arcade. So this is the artery that connects the SMA to the celiac artery. You don't get to see it all here, but that's where this is. So when you inject this thing here, you see this pseudoaneurysm right here. And you also see the portal system filling up here. So the portal system is filling at the same time. So somehow there's a mesenteric pseudoaneurysm here and then a connection to the portal system up here. So this is an arterial portal fistula. My computer does not want to behave. And again, challenging. But you can see a stent here. This was a stent that was placed by ERCP, which injured the artery here and resulted in this fistula. And so this can be treated with coil embolization. Is the best way to treat a pseudoaneurysm. Whenever you treat a pseudoaneurysm, you need to treat both sides of it. We say front door and back door. So you need to put coils here on the front and coils here on the back, just so this thing doesn't recur, so that no flow goes from the front and no flow comes backwards from the back. So all pseudoaneurysms really have to be treated on both sides, or it won't work. So again, this is an AP image. This is an image from the right internal carotid artery. So A is the right internal carotid artery, B is the anterior cerebral artery, and C is the middle cerebral artery. So the last one is, do you pack the pseudoaneurysm with coils also, or just cut it off from the front and the back? So if you cut it off from the, again, there's no absolute right way to do this, but the best way is to treat the front of it and the back of it. If you treat the front of it and the back of it, you really don't have to pack the pseudoaneurysm itself, because it's cut off on both sides and it will not recur. So some people feel the aneurysm, pseudoaneurysm. You don't have to. You just have to make sure that both the front and back are closed entirely. All right, so this is the bladder here, Foley catheter in the bladder. You can see from the right side of catheter going up and over the aorta and down into the internal iliac artery here. So this is down in the internal iliac artery. And when you play this, you can see the blush right here next to the Foley catheter. So this is prostate artery embolization, basically embolizing the prostate. So we do this typically in patients who have lower urinary tract symptoms, such as frequent urination or urination at night. And for prostate artery embolization, it's kind of like a benign tumor. And whenever you think of tumors in general, you should use really small particles, because you want it to penetrate really deeply into the prostate and basically to destroy it in general. So we use small particles for prostate embolization.
Dr. Chick, was there a way to know that that was a male pelvis, or that was, I thought this was a uterine embolization?
There's no great way. The uterine one is later. I have one of those too, so you'll see that. I would say probably, so the uterus tends to be, it's certainly tricky. And even this, I added this to be a little bit helpful, but it's really not that helpful either. The key here, I think, is that the hemisphere of the prostate is relatively small. And it's kind of like directly next to the Foley here, which we usually use the Foley as a marker for when we're doing prostate artery embolization to know that you're in the right vessels, because the hemisphere tends to be right next to it and go right through this region. The uterus, as you'll see later, is much, much larger. The other thing is uterine arteries tend to be really, really, really corkscrewy. They're and very large. So when you see a uterine artery kind of in life, you know it's a uterine artery just right away because it's so large and it's so serpiginous. This one is kind of like just not that impressive to me. So it's a good question. I don't think it's hard to know. I would say just the volume of distribution right here is relatively small. All right. So this is a popliteal artery aneurysm. So you can see the popliteal artery right here. And then on this side, you see it's thrombosed and you see the calcification around the rim of it. So a thrombosed popliteal artery aneurysm. And this is a lower extremity runoff. And you can see basically this is where the aneurysm itself is, and it's essentially thrombosed. So you have some flow before it and you have some flow after it. But the aneurysm itself is kind of thrombosed right here. So typically these patients present with some sort of either knee pain or foot pain because you're showering some of that thrombotic material that's in the aneurysm down the foot. So you basically get like a cold foot. So in the past, we used to do bypass around these patients, but recently sort of the study has shown that stent graft placement across this region is just as effective. It's kind of a somewhat tough area to stent because the stents have to be resistant to a lot of like crush forces and movement. So probably still would have bypass if that's an answer, but stenting is also possible. I think it's probably a little bit of both. Is the distal flow due to collateralization or non-occlusive thrombus? I mean, I think it's sort of non-occlusive here. You can see this in pathway through, so that's some of the non-occlusive, but there is some collateralization as well because you can see these little guys are trying to bypass it also. So it's a common of both. So cystic medial degeneration is something always on the differential, and they absolutely love that as well. I don't want to confuse you guys because I've never even seen a case of it, and I can't even remember medial head of something, gastroc or something. Someone has to help me here. Something like that, right? I would look it up on Wikipedia or Radiopedia because they definitely for popliteal artery aneurysm love cystic medial degeneration, and it's just a definition of which I don't want to give you the wrong one. So look it up. All right. So this is what we call a type 2 endoleak, and they really like the endoleaks as well, or just the definition. So type 2 endoleak is the most common endoleak that we have. So you can see the aortic aneurysm repair here. You can see the stent graft in the aorta and in the iliacs down here faintly. So this is a catheter that's in the internal iliac artery. So this is the internal iliac, and then going up the internal iliac here, this is an iliolumbar pathway. So this is the iliolumbar here, and then this thing dumps into this hypervascular area adjacent to the stent graft itself. So basically this is a stent graft here, but there's a leak around the stent itself. Called an endoleak, and so this is by the iliolumbar pathway. So these can be treated in a variety of ways. Typically, we use some kind of liquid embolic in here, like glue or onyx, which is this ethylene vinyl copolymer. So they're basically both like glue. And so you want to glue this whole thing shut so it doesn't enlarge. And then typically we coil off the vessel afterwards. Is the way. There's a variety of ways to do it. But we typically glue it and then coil it afterwards. So type 2 endoleak. Someone is asking, when should you do surveillance only for type 2 endoleak? So there's variability in that as well. It depends if it's enlarging or not. There's no, if you see an endoleak, typically again, based on size, if it's a small endoleak, there's not an absolute cutoff. But if it's kind of relatively small, it's not unreasonable to get a 6-month follow-up and just see if it's stabilized. Most endoleaks at some point do require treatment, but just because you see it doesn't mean you need to treat it right away. If it's enlarging over time, which most of them do, they require treatment. So definitely look at all the 5 types of endoleaks and just memorize the definitions because they do like that. So type 2 endoleak is usually not seen at the time of stent placement. It tends to recur over time because technically the aneurysm sac is excluded by the stent graft, and then the sac around it tends to recruit other vessels. So it's not there at the original time. It tends to kind of suck in these vessels over time, and it develops after the procedure itself. All right, so the skull here is a little bit some of the giveaway. So it's an incredibly, incredibly hypervascular mass that's right over the nose. So this is a JNA, or juvenile nasopharyngeal angiofibroma. They're super, super vascular on angio. They come from the external carotid artery. So this is an image of the external carotid artery. And specifically, they come most commonly from the maxillary artery, or we call that the IMAX. So typically we use some sort of particle, again, because it's a tumor. Tumors, we use small particles, or you can use gel foam because it's a temporary agent. And typically we embolize these, and then they go and have surgical resection afterwards. And the thought is just embolize them so that they're not bleeding aggressively when you're doing surgery. So JNA, very classic by just how hypervascular it is there. So this is a lingual artery embolization. So you can picture this is the tongue right here. And you see this little outpouching here. This is pseudoaneurysm. This patient had tongue cancer and prior radiation. So this is pseudoaneurysm off the lingual artery. So again, the treatment of pseudoaneurysms is coil off both sides. So coil the back side and coil the front side. You can coil the aneurysm sac if you want, but you just need to coil both sides of it, and then it won't recur. So this is another thing that they really like. So this is a standing wave. Some people would think, so this is superior catheters in the superior mesenteric artery, and you can see these very, very regular patterns, nearly identical of the entire thing. So it's way too regular and way too even to be FMD or fibromuscular dysplasia. So this is a standing wave. It's not FMD. So this is just an artifact. It's just incidental. It can be anywhere in the body. SMA is quite common where it is. People think it's related to the rate of injection, how fast you're injecting, or perhaps the vasodilatation or the vasoconstriction of the vessel itself. So in order to fix this, you could just do an injection at a different rate, a different speed. Or you could just wait and try again. Or some people say give vasodilators to change the dilatation of the vessel. But the key is this is totally artifactual. You do not want an angioplasty like this, like it's FMD, because it's just too regular. It's not FMD. It's just totally an artifact. Leave it alone. All right, so it's a little bit hard to tell here, but this is the right side of the leg. So this is a sheath right here that's in the right common femoral artery. So this is an RAO, or right anterior oblique, and you can tell that because the side that you're working on splays out the SFA, and the profunda. So if I'm telling you, this is the right side of the body. And so you can see that these guys are laid out. So they're opened up here. So that's the same side that you're working on. So RAO, if you're working on the right, lays this guy out. So A is the profunda, or the profunda femoris. B is the SFA, or superficial femoral artery. C here is the deep circumflex iliac. The deep circumflex iliac is one of the arteries that comes off of the common femoral artery or the external iliac artery, and it always goes lateral. So the key is to differentiate between the inferior epigastric artery and the lateral circumflex. So the inferior epigastric always goes medial, and it's the one that gives you a rectus sheath hematoma. Whenever you look for like rectus sheath bleeds, it always comes from this guy, the inferior epigastric, and it always comes medial, where the one that's lateral is the lateral circumflex. And then E is just a common femoral artery, and this is the area that you want to access because it's the area that you can hold pressure right over the femoral head. So this is an intercostal artery. So you've got a catheter here in one of the intercostal arteries. They all look like this. You can kind of see it's up here in the chest. You can kind of see the ribs. Lumbar arteries, which are lower down, look very similar. So you see this intercostal artery, then you see this region of extravasation here, or basically pouring out of contrast. So this is an injury to one of the intercostal arteries, so commonly from a thoracentesis or any kind of chest surgery. Again, it's treated kind of like a pseudoaneurysm, where you would coil once, you coil the back side of it, and then you'd also coil the front side of it so it doesn't continue to leak. You could do other things. You could glue it shut. You could use gel foam, but typically across bleeding, extravasation, or pseudoaneurysms, we use coils for the most part. But glue is another option. So this is an example of what either an ovarian or a uterine artery looks like. So ovarian and uterine arteries, this is the real like crazy tortuosity that I was talking about. They always sort of look like this. This is an ovarian. Uterine looks very similar. So this is a challenging case. So this is a postpartum hemorrhage. So this catheter here is in the aorta. You can see the aorta filling, and you can see both sides. And then you see this thing coming off of the aorta right here, coming down, 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 and then this giant pseudoaneurysm down here. So this is the ovarian arteries or gonadal arteries always come off the aorta. And this is an injury during post C-section or birth in general. So this is an injury to the ovarian artery here with a giant pseudoaneurysm here. And again, pseudoaneurysms you typically treat with coils. So you can coil across this on both sides, or again, you can use glue for that too. All right, so again, this is a renal arteriogram or right renal arteriogram. So the catheter is in the renal artery. So the injection rate for this is 5 mLs per second for a total of 10 mLs. And you can see the renal artery branches, and then you can see pseudoaneurysm here. You can see probably some extravasation here. So this is just multiple injuries to the renal artery here. So this is common in either a biopsy or very common with partial nephrectomy. And again, for pseudoaneurysms or any kind of extravasation, typically use coils. Try to coil both across the whole thing if you can, or glue it. If it's an end artery, which sometimes the renal arteries are, you could just put a single coil in it, and you basically wouldn't have to coil on the other side because it's really the end of the artery. All right, so in a patient with fever and rigors, this is an abscess, so hepatic abscess. So the best way to drain this is the most subcostal. Come as low as you can. So B is the best way to drain this. And that's mainly, again, to avoid the pleural reflections, like the same thing in the kidney. You don't want to come too high. There's no absolute level, but come as low as possible to prevent creating a fistula between this abscess and the pleura here. To basically get a hepatic abscess in the pleural space. So come as low as possible. And also C is not a great one here because this is where the neurovascular bundle and the nerve and the artery run under the rib here. So you don't want to hit those, or you could get an intercostal injury like that one that we saw earlier. And these guys are just too high up here. So come as low as possible. So this is a thoracic aortogram. So this candy cane view is always obtained by using LAO and left anterior oblique. Sounds kind of silly. Who cares? I agree. But they love to test this on my test as well. This one I think is the one they always like. So the thoracic aortogram candy cane view is always obtained in an LAO view. I don't really know how to explain that. You guys know it definitely better than I do, but just candy cane like this is always LAO. This is again, the right lower extremity. So if you want to lay out the profunda and the SFA, you always go ipsilateral or towards the same side to lay them out. So this is right. So this is RAO. Again, I don't have a great way to memorize them, but I would memorize some of the views and also some of the injection rates. There aren't a lot, but they certainly did ask on my test. So this is the patient that had superior vena cava syndrome. So you can see the heart right here. This is the superior vena cava here. So this is a stent graft that's going from the left brachiocephalic vein down to the superior vena cava. It's going from the right brachiocephalic vein down to the superior vena cava. So we'd say this is superior vena cava stent graft reconstruction. During these cases, the superior vena cava is a pretty dangerous area to work in because it's not really protected by anything. It's got lung on one side and pericardium here. So often if you're too aggressive in these areas or you angioplasty too greatly or you do things, you can injure that and cause either basically death quite easily with either pericardial injury or pleural injury. So this patient had a pericardial injury, and this is what a pericardial drain looks like. So this is a drain that's in the heart, in the pericardium, is the complication here. So this is an aortogram. You have a catheter in the aorta here, and you can see both iliac vasculatures here. These are the internal iliacs coming down here. And with progressive things, you see this little blush here, then you see this little blush here, then you see this like prolonged blush here. So this is a penile blush or cavernosal blush. It always looks like this, always, and it's quite often fooled or people think it's a bleed, and it has been embolized before. And it's certainly not a thing that you really want to embolize. So this is cavernosal blush, penile blush, and it's a do not touch lesion. Leave it alone. So here you have a catheter in both common femoral veins, and then this is the inferior vena cava coming up here. Looks quite large in general just by looking at it. So this is mega cava. Another thing that they certainly like. So mega cava is any IVC greater than 28 millimeters. So in various treatments for that, you can do a few things. You could place a bird's nest filter in here, which is just a permanent filter that's quite large, which is the largest filter that we have and is designed for large IVCs. Or you could place two regular filters in the iliac veins down here. Those are two possible options. But they definitely like mega cava and the definition of greater than 28 millimeters. So here you can see the trachea and the bronchi. So this is a catheter that's in one of the bronchial arteries here. So this is a bronchial artery embolization. So you can see the bronchial arteries here. So bronchial arteries always look very chaotic and tortuous like this. They always just look like they feed many, many arteries over the chest area or the hemithorax here. So bronchial artery embolization, there's only so hemoptysis is the reason to do these. So technically the patients have to have massive hemoptysis, which is greater than 300 mLs in a day, is the definition. And technically the only indications to do a bronchial artery embolization are cystic fibrosis / bronchiectasis or chronic infection, typically tuberculosis. Cancer, lung cancer is not a reason to do bronchial artery embolization. Doesn't mean you can't do it. It just tends not to work well because the tumor is much smarter and it tends to outgrow the blood supply. So the one thing, two very important things to know about bronchial artery embolization. One, to get out as far as you can with a microcatheter because off of the bronchial arteries come the spinal arteries, which look like hairpin arteries, which come midline. I don't have one here, but if you embolize too centrally, particles or debris can go down those hairpin arteries and it can result in paralysis. And that's like the biggest lawsuit on earth. So the most important thing is to always use a microcatheter and always come out further. That's one safety measure. And the second one is to use giant particles. We typically think 500 to 900 microns because the particles are so big that they can't go down those spinal arteries if you just don't see them. So those are two protective mechanisms for that. The other thing is whenever you're treating bronchial arteries, never use coils. So just like the AML, you never, ever want to use coils because these guys are really smart and they tend to recruit all over the place. And once you place coils in here, you can never get in again. And it just kind of blocks your supply and makes it really challenging. So bronchial arteries equals never coil. So typically we just use large particles to treat bronchial arteries. So this is bilateral lower extremity ascending venogram. So you've got two catheters down here in the common femoral veins. You're coming up, and you see this band-like irregularity right here. So this is May-Thurner syndrome, which is no longer called May-Thurner syndrome anymore. It's called iliac vein compression syndrome. So it's compression of the left common iliac vein by the right common iliac artery. So this is left common iliac vein right here, and this is the band where the right common iliac artery is going over it. And this is also a hint that there's a problem here. This is the ascending lumbar vein, which tells you this is basically like a pop-off mechanism because you've got some kind of occlusion here. So the blood is going around this way. So the treatment for May-Thurner syndrome is stent placement right across here. So this is lung cancer, and they love this one too, like a million different ways, how the best approach to how to get to the lesion. So B is the best way to get here. So always the shortest distance to the lesion and always perpendicular to the pleural surface has the lowest risk of a pneumothorax. So the risk of pneumothorax after this is about up to 33%. And if you go the shortest distance and keep perpendicular, that should reduce it. So B is the best answer. So this is a kid renal arteriogram, and this is renal artery stenosis. So you can see right here, this change in arterial caliber here. So stenosis is defined as anything less than 50% or greater than 50% narrowing of the regions adjacent to it. Is typically what we think of being an actual stenosis. So you can see this reduction in 50% of the lumen compared to it next to it. So typically this results in renovascular hypertension. And then since it's a kid, we try to initially do angioplasty here, like FMD. If you ultimately have to place a stent, you can, but try not to if you can avoid it. Just because you don't want to put foreign bodies in children, they're going to grow. The stent might be too small in the future. So it's best to just do serial angioplasties until they get older. And if you absolutely have to stent later, you can. All right, again, so this is an AP, anterior posterior. This is a vertebral artery injection. So A is the vertebral artery. B is the basilar artery. C here is the superior cerebellar artery. And D is the posterior cerebral. They definitely like head anatomy too, head and neck arterial supply. So take a quick look at some of those. So this is the one, this is the uterine artery embolization. To contrast with your prostate artery embolization, for one, you can see this one has an intrauterine device right here, IUD, which is a little bit, one hint here. One, the uterus tends to be so much bigger. Usually these patients have multiple fibroids, they're very gravid. It just looks like a huge organ compared to the little prostate. They also, it's so pushing the artery away so much that's even hard to tell, but they're usually very, very tortuous like this. So this is uterine artery arteriography before embolization. So this is uterine artery embolization. We also call this fibroid artery or fibroid embolization. So typically these patients present with either menorrhagia or pain and fullness. So uterine artery embolization works best for menorrhagia. It works the best in general for that. Bulk symptoms, pain or swelling, it works okay for, but not as good. So if you talk to patients or anything, you tell them that it works if they have heavy bleeding. That's what it's like. That's what it's most likely going to work for. But bulk symptoms, it works reasonably for it as well. So here we use particles. Normally, when you think of tumors, you think of small particles. We tend to use particles a little bit larger for this because we don't want to kill the uterus itself. We only want to kill the fibroids. So we basically use slightly larger particles, 500 to 700s, instead of the really, really small ones like 1 to 300s, which we use for tumors, because we only want to make the fibroids ischemic and not kill the uterus itself. Beyond what you need to know, but particles is what we use. So this is an iliocaval venogram. So your catheter is down here in the left iliac vein, and it's flowing up here towards the heart through the inferior vena cava. You can see the renal vein here and the renal vein over here, and the hepatic veins up here. So this is a iliocaval venogram or inferior vena cava venogram. And the injection rate for this is 15 mLs per second for a total of 30 mLs. Again, this is quite large. So a larger number should be the very first number, 15 mLs for a total of 30. Some of these you just gotta semi-memorize if it's important to you. All right, this is a patient that has a pathologic fracture of the right humerus right here from our metastatic RCC. So typically we embolize these before surgical fixation. So here you can see the catheter is actually coming from up the arm. So this is either coming from a radial artery or a brachial artery somewhere off the screen here. And this is a circumflex humeral artery here, which is the artery that always supplies the humeral head and the humeral neck, and this hypervascular mass here, which you can see. So since it's a tumor again, we think of small particles. So we use 1 to 300 is what we call 1 to 300 micron particles to treat this hypervascular mass here. And then they either have resection or surgical fixation afterwards. Again, so this is obtained, candy cane view is always obtained from the LAO point of view here. So this is the internal thoracic artery right here, or the internal mammary artery. B here is the left subclavian artery. C is the brachiocephalic artery. D is the left common carotid, and E is the left vertebral. All right, so this is a bilateral lower extremity injection. So again, this is an AP view here. So this is a duplicated inferior vena cava. You should just really have one. Obviously, this side should cross over and go up. Here's the tiny remnant bridge where it should have formed, but it didn't. So you have two separate IVCs here, a right-sided IVC and a left-sided IVC, and this tiny little bridge. So our stents here are all throughout the right-sided IVC. So this is in the right common iliac, you could say right IVC, right common iliac vein, right external iliac vein, and then right common femoral vein down here. So this is a trauma patient. So this is a pelvic arteriogram of the internal iliac artery. So the internal iliac artery has two divisions, the anterior and the posterior division. So this is what the posterior division looks like here. It goes kind of splays out in a fan-like appearance to the butt, basically. And then you should also have an anterior division, which comes down the middle here, midline, and supplies the uterus and the bladder and so forth. So you can see this truncation right here. So this is a transection of the anterior division of the internal iliac artery. This is almost always related to trauma. And for most pelvic injuries, or we use gel foam because it's a temporary agent, and you at some point you don't want to basically permanently embolize the whole pelvis. You want to allow it to heal. Gel foam disappears in about 4 weeks, typically. So over 4 weeks, the patient heals, and then it basically heals normal and then goes back to normal. Another option is to just put a coil right here to coil off this truncation right here. So there's some duplication. So there is there's not a lot of fear in embolizing one whole side of the pelvis if you have to. So you could coil off the entire internal iliac artery basically with no adverse events because you have the other side to compensate. But this is just a truncation of the anterior division, trauma, and treat with coils. Someone asked, how do we know that's not a duplicated aorta? I don't really know.
That was for the last one.
Yeah, exactly. That other guy. I don't know that you can really have a duplicated aorta. Maybe you could. I mean, I've never really seen or heard of it. One thing that would be helpful here is it's going away from you, going towards the heart. So it's a vein. If you're looking the direction that it's going, if it were the aorta, it'd be going the other way towards the legs. The flow would also be much faster if it were the aorta. So this is another thing that they love. So you can see the ET tube here. And you can see the chest. So you're somewhere in the chest. So this is a catheter that's in the pulmonary artery here. You can see one of the pulmonary arteries filling. Then you see this big saccular thing here filling. Then you see an early draining vein here, the pulmonary vein. So this is a PAVM or a pulmonary arteriovenous malformation. These patients who have a lot of these, you always think of HHT or Osler-Weber-Rendu. And we work up these patients these patients have genetic counseling, and we work up family members for these because it runs in families, obviously. These patients typically first come to our attention because they get a brain abscess or some kind of stroke because this is a shunt that bypasses the lungs. So basically any bacterial, denture infection, anything can basically go right through the shunt, entirely bypass the lungs, go to the left side of the heart, then go to the brain or go down the legs or whatever. So patients with PAVMs typically present with brain abscesses or a stroke. And we embolize these using coils. You don't want to use any kind of glue or gel foam or anything like that because that will go right through here. It's basically a bypass around the lung, and it'll just go straight to the brain, and you'll cause a stroke. Let's see. Question 49. Just have one question on this. What is that variant anatomy with the separated origin of the left vertebral artery? I don't think it's actually separated here. You just can't really tell. It comes right off of the axillosubclavian here. It's just the view. And the draining vein on this guy. So this is the artery here that's going outwards towards the sac. This one here goes out towards the sac, fills the sac here, and then the draining vein is this guy right here. It's more just kind of like watching how it fills. So it fills out, then it comes back. It would be more clear. the point was just to show what a PAVM kind of looks like. Yeah, so someone wants to know, why is it okay to coil off a pulmonary AVM but not a bronchial artery bleed? So it's not a stupid question anyway. So the bronchial arteries tend to be like lung tumors, cystic fibrosis, infections tend to absolutely recruit from the pulmonary, from the bronchial arteries. They tend to just suck from the bronchial arteries for what it's worth. So you typically never really get a bleed or anything from the pulmonary arteries. You just, I don't know, for whatever physiologic reason, you don't get anything like that. So bronchial artery bleeds, there's no like way to think about it or know why, but bronchial arteries tend to be recruited, tend to get sucked by tumors and cystic fibrosis. So you don't want to coil them off. These guys, the pulmonary arteries, they just tend to just kind of live there. They don't get recruited by anything. They tend never to bleed. So you don't have to worry about having to reaccess them in the future. But there's not a great reason. The big thing is with PAVMs, it is a bypass around the lung. So you absolutely do not want to use any kind of liquid here because you'll certainly cause a stroke. So this is a thoracic arteriogram, aortogram again, from an LAO view. And if you look carefully here, you can see, so this is the right common carotid, and up the right common carotid here, up is this pseudoaneurysm off here. So this is a carotid blowout or an injury to the carotid artery from prior radiation therapy. So this can either be repaired surgically or you can put a stent graft across it.
Oh, sorry. Could you point out the injury on that one again?
So if you just watch it play, it's right here.
Okay.
So right there, it's just going up the normal carotid. Then it's just basically, we call that a blowout, where you just got that saccular kind of pseudoaneurysm there. And you want to use a stent graft here. So there's two differences. You have a bare metal stent, which we just call a stent. And then a stent graft is a stent with covered material on it. So you want to cover this thing and exclude it entirely. So we use a stent graft that has graft material on it. This person does have some sort of, it's kind of not exactly straightforward. This is a multi-bypass patient. So the anatomy is 100% abnormal. So this is an aortogram, and you can tell that here because as you inject, the flow is going away from you and down the feet. So aorta, iliac vasculature here, internal iliac vasculature here. So the injection rate for the aorta is 30 mLs per second for a total of 30 mLs. Again, it's the largest vessel in the body. So the first number should be the largest. So if you memorize anything, I don't know how to explain them super well. The renal artery is 5 mLs per second for a total of 10 mLs. The IVC is 15 mLs per second for a total of 30 mLs. And the aorta is 30 mLs per second for a total of 30 mLs. Those are at least the big vessels that, and I had, I think, IVC on mine and renal artery. So this is a biliary drainage procedure. So you can see the biliary ducts right here. So this is a duodenal stent down here. These are the biliary ducts here. This is a needle targeting the biliary ducts, and then the wire in the biliary ducts here, and then ultimately putting drains through the biliary duct here into the duodenum itself. So there are only 3 indications for biliary drainage. One is active cholangitis. The second is pruritus or uncontrolled itching. And the third is hyperbilirubinemia, but with a need to lower it to give chemotherapy. So this is also something that did test on, and it's a trick question. Obstruction is not an indication for biliary drainage. Despite what you might think, does not matter. And actually hyperbilirubinemia even if it's 10,000, is not an indication for biliary drainage. The only indication is if that bilirubinemia is causing uncontrolled itching, or you're trying to give chemotherapy, but you can't because it's too high. But just an elevated bilirubin and obstruction in general is not an indication to do it. So this is an image of a IVC iliocaval venography or inferior vena cava venography. And this is a circumaortic renal vein right here. This nubbin right here. Again, something they like to test for some reason. So you should always put the filter, the apex of the filter below the lowest vein here. Because if you put the filter above it, this is again a bypass channel that could go around the filter entirely. So if your filter is down below it, everything below all these veins will get trapped in the filter. So you always put the filter below the lowest renal vein of any kind. So circumaortic renal vein counts as one. So every time the filter goes below it. So you can see the circumaortic renal vein right here, and you can see the normal renal veins up here. And definitely something they like to test. I'm not sure why, but so circumaortic here, and the normal renal veins are here and here. So this is multiple visceral aneurysms. So this is the superior mesenteric artery right here. And then this is the IPDA, or the inferior pancreaticoduodenal arcade. So that connects the superior mesenteric artery all the way through here. This is the gastroduodenal artery, and then that connects up to the celiac artery up here. So this is the celiac artery here, and this is the SMA. So this is kind of a strange thing. Why would you, when you fill the SMA, why would you fill all the way backwards through this entire pathway? So it could be Sam, but there's an even better answer here, because so when you inject the SMA, you should never see this thing fill backwards here, unless you have some kind of problem like celiac artery stenosis. So this celiac here is totally occluded. This is a retrograde pathway that's filling the hepatic arteries here and the splenic artery. So when you inject, so nothing is going through here normally. So when you inject the SMA, this is a safety route through the IPDA to fill the hepatic arteries and to fill the splenic artery. So these arteries are kind of small, and they're not meant to tolerate all this really high pressure. So over time, they develop these sort of degenerative aneurysms. So these are aneurysms from the high flow through the IPDA. So one option would be, if they're bleeding, to coil them off. But you got to be careful, because if you coil them off entirely, then you basically get ischemia to the spleen and ischemia to the hepatic artery. So if you were to do that, you'd have to open up the celiac artery here as well and put some kind of stent there. All right, last two. So this one is, so the catheter here is from the neck into the left renal vein here. So this is a left renal venogram. And when you inject the left renal vein, you see the entire left ovarian vein, gonadal vein, and then all the way across here. So that should never fill like that. It should normally just fill out into the IVC, unless you have some kind of stenosis right here. So this is left renal vein compression syndrome, also known as nutcracker syndrome. So you have squishing of the left renal vein between the aorta and the SMA. So when you inject, all the blood is being forced down the gonadal vein, forced through the pelvic varices and internal pelvic veins, and then up the other side. So this is always not what nutcracker looks like. The best treatment, or treatment of choice, is renal vein transposition. But if you can't do that, you could place a stent across this region, but it's kind of a tough area to stent in. The stent tends to slip, migrate, and it can be a little bit problematic. All right, and the last one here. So this is some variant anatomy. So this is an injection from the celiac artery here. So this tiny little one is the left gastric artery here, and B is the splenic artery. but you don't see the hepatic artery like you normally should. So the hepatic artery should be over here. So this is a special variant called the lenogastric trunk, or splenogastric trunk is what people call it. So it's just a short left gastric plus a splenic artery here. And then if off the SMA down here, this is where you have your replaced common hepatic artery. So this is the SMA. This is the common hepatic artery. This is the gastroduodenal artery here, E. And then this is the proper hepatic artery. And then you've got your left hepatic artery and your right hepatic artery. So with that, thank you guys. I have hundreds more cases if you ever want more. I know that was long. And feel free to email me anything, any questions you have, anything, you can email me, you can call me, you can do anything. I have 10,000 cases. And if you have any questions, seriously, email me. And if you would fill out that survey, I'd be extremely grateful.
Thank you so much, Dr. Chick. That was awesome. So many good cases.
And you guys will be fine, don't worry.
I think you had a post session survey that you wanted them to fill out. Yeah, if you send that to me, then I can post that in Discord and have people fill it out.
I absolutely will. And I'll do that right now. And thank you guys for having me. And if you need anything else, let me know.
Thank you so much.
Yeah, this was really amazing. Thank you so much for doing this, especially after you had such a busy night. We really appreciate it.
All good. I'll go to bed now. Thank you, guys.
Bye.
Bye.
Amina, I'll go ahead and end the meeting.
Okay.
We can chat later if we want.
Yeah, you can, just call me. We can talk about it.
Okay.
Okay.